Next, I have the pleasure of introducing Dr. Saher Suleman. She is a pediatric epileptologist in our Comprehensive Epilepsy Center. She completed her undergraduate at Georgia Institute of Technology, her medical degree from the Medical College of Georgia at Augusta University, and then was in Phoenix for her training in general pediatrics, at the Barrow Neurological Institute at Phoenix Children's for her training in neurology, pediatric neurology and epilepsy. She will be talking to us this morning about updates on anti-seizure medications.
Good morning, everyone. So this morning we're going to be talking about newer anti-seizure medications. Really the biggest focus of this talk is going to be on new anti-seizure rescue medications, the currently approved FDA rescue medications, when to use them, how to use them, and then briefly at the end of the talk, we'll briefly talk about some of the newer anti-seizure maintenance medications. So with that, let's get started with talking about seizure rescue medications. So what are they? This is an as-needed medication that's designed to be used by non-medical professionals outside the hospital setting. So this may be parents, this may be teachers, this may be the school nurse, this may be other relatives. And when do we use them? So it's really targeted to be used when a seizure becomes an emergency or it's unlikely to stop without medication. So how do we define that? To be more clear, it's approved for use for acute treatment of intermittent stereotypic episodes of frequent seizure activity, so such as seizure clusters or acute repetitive seizures that are distinct from a patient's usual seizure pattern. This may be much more easier in patients who have infrequent seizures, but with patients who are more refractory or may have more frequent seizures, this becomes a little more challenging and a little bit more of an art where you kind of have to figure out what's a pattern, where to set that parameter, when to use the rescue medication at home. So the rescue medications can be used for status epilepticus, febrile seizures, catamenial epilepsies, and they're available to be administered intranasally, buccally, sublingually, rectally, and enterally. So when do we use these rescue seizure medications? Let's dive a little bit deeper. So they can, of course, be used for status epilepticus, so that's a seizure longer than 5 minutes, and this really applies to more generalized convulsive seizures. And they can be used for seizure clusters. Now, this is a little bit more challenging. There's not really a set criteria for a seizure cluster, and the criteria really varies throughout the literature. But generally, it's more along the lines of 3 or more seizures in 1 hour. Seizure rescue medications can also be used for febrile seizures, so especially when they occur in clusters, when they tend to be really prolonged, and especially when the patient lives far away or doesn't have access to nearby healthcare. And lastly, catamenial epilepsy. So this is a cyclical increase in seizure frequency associated with a woman's menstrual cycle. So oftentimes they'll get a prescription of a rescue medication to use around the time of their menstrual cycle. So what makes an ideal rescue medication? There are certain characteristics that make a medication ideal for rescue use. So these should be effective against multiple seizure types. They should be safe to use at the therapeutic dose. They should be safe and quick and easy to administer. And they should be potent in small volumes. They should have a rapid onset of action and a long duration of action. So let's review the different routes we have available for these medications. So we'll start with the intranasal route. Intranasally, it's rapidly absorbed through the vascular nasal mucosa, and it has a rapid onset of action, so usually within 1 to 5 minutes. With this route, you avoid first-pass metabolism, and with this route, it's generally really easy to use and, of course, more socially acceptable, less embarrassment for the family and for the patient compared to the rectal route. So the rectal route, it's rapidly absorbed through the rectal mucosa, and actually up until 2019, the only FDA-approved rescue medication was a rectal medication. Like we discussed, that the challenges associated with this medication can be, social embarrassment and discomfort for both the patient and the family, but really there are other things to consider as well. So this medication, this route of administration, can be really challenging to use in larger patients or patients with limited mobility. So patients who are in a wheelchair or patients with spasticity. So because of these challenges, it really limits our use when we have older patients. And lastly, rescue medications can be administered buccally, sublingually, or enterally. Now, there's no current FDA-approved medication via one of these routes, but as you can imagine, oftentimes families do find it to be a much more easier route of administration. It does have rapid absorption when you use it sublingually or buccally, but we do need to keep in mind that it may be a little bit longer when you're trying to use it enterally because it does have to go through first-pass metabolism. Now, there are some disadvantages to keep in mind if you're going to use this route. So the risk of aspiration, the risk of injury to the caregiver. So, especially if they're having a convulsive seizure, their jaws tighten, they're stiff, you really need to provide clear advice and instructions for the family on how to use them. And some of these formulations need to be refrigerated, which may be challenging for some families. So let's review the current medications we have available. So the first is, of course, rectal diazepam or Diastat. This was the only FDA-approved rescue medication until 2019. It's approved for use in patients 2 years and older. It comes in this prepackaged rectal device, and this Acu device actually has a setting where the dose can be adjusted and set, so it's usually the pharmacist who will set it to the correct dose. And it has a lot of supportive data showing its effectiveness, showing that reduction in seizure occurrence over 12 hours, a long duration of action, and fast absorption within 5 minutes. So the really major side effects we think about with this medication, with rectal diazepam, is respiratory depression. This can range from 0 to 6%, and one of the larger studies of about 2 million doses, there were 9 respiratory events and 3 deaths, all of which were really associated with prolonged seizures. It's not recommended for infants less than 6 months old due to the risk of prolonged CNS depression in this age group. Dosing for rectal diazepam is based on age and weight, and this can be easily accessed from the FDA Diastat drug sheet as well as other resources like UpToDate. Let's move on to intranasal diazepam or Valtoco. This was approved in January 2020 for patients 6 years of age or older. It does have bioavailability that's comparable to IV diazepam, and it works pretty rapidly with a time to maximum concentration of about 1.5 hours. The really common side effects that we need to consider are nosebleeds, somnolence, headache, mild discomfort, and really no significant respiratory depression has been reported with intranasal diazepam. We do need to be wary of using this medication in neonates and infants because it can be associated with a gasping syndrome with metabolic acidosis, CNS depression, and gasping respiration. So caution with use in younger populations. The intranasal diazepam dosing is also weight-based and age-based. And again, this data can be easily obtained from the FDA drug sheet as well as the manufacturer's website. So lastly, we'll move on to intranasal midazolam or Nasolam. This was approved in May 2019 for patients 12 years of age and older. Again, it's been shown to be as equally effective as IV diazepam for seizures that have been going on for at least 10 minutes. It's actually shown superior efficacy compared to rectal diazepam with a median seizure duration that's 19 minutes shorter. And again, it has a really rapid onset of action in 10 minutes and reaches peak concentration in about 17 minutes. It does have a shorter half-life, so which may be a good thing as it's less likely to accumulate with repeated doses. Now, adverse effects are similar to the other intranasal medications, so nasal discomfort, throat irritation, rhinorrhea, headache, and impaired awareness. Now, the thing to keep in mind with this medication is that the dose is not weight-based. It comes as a 5 milligram dose that you can administer, and then a second dose can be repeated if the seizure is ongoing. So this kind of limits us dosing it appropriately for younger kids when they're less than 25 kilograms. Now, I wanted to share this I wanted to share this video from the Epilepsy Foundation. They review how to use different anti-seizure rescue medications. So we'll look at a brief portion of it, looking at nasal administration. So. Okay, the sound may not be working, but this is a great resource for both patients and families. The Epilepsy Foundation has a lot of other great videos that can be great resources for patients' families on how to use the different rescue medications and how to provide care for patients having seizures. And lastly, we'll touch base on oral clonazepam. This doesn't have FDA approval for rescue treatment, but we still often use it as a rescue medication due to several advantages, such as ease of administration for family. It comes as oral wafers and oral dispersible tablets that can be prescribed and easy for use for families. It can be used for prolonged seizures and seizure clusters and febrile seizure prophylaxis. And a lot of families feel like it's equally as effective as rectal diazepam. So the common side effects, of course, include drowsiness and fatigue. It's rapidly absorbed. It has a pretty good long half-life. And the dosing is about 0.1 to 0.03 milligrams per kilogram per day. I really like this figure. I think it's a great quick visual guide for dosing based on their size, and I use it all the time in my head. Keep in mind that other oral rescue medications, they're also available, or lorazepam and midazolam. So this is a quick chart showing the current FDA-approved rescue medication. It's a quick reference guide showing the age range for approval, the half-life, and the cost. Can be a quick reference for prescribers. Lastly, we'll briefly review some of the maintenance anti-seizure medications. So in the past several years, we've had a rapid increase in new maintenance anti-seizure medications that have been approved. And you may have encountered some of these in the patient populations you see. So I won't go through all of them, but we'll kind of briefly review some of the ones that you may have come across. So really, rufinamide and cannabidiol, or Epidiolex, is approved for Lennox-Gastaut syndrome. Cannabidiol is also approved for Dravet syndrome and tuberous sclerosis complex. Felbamate, brivaracetam, and perampanel are used for both focal seizures and generalized seizures, and cenobamate is really for more focal seizures. The common side effects for these medications are really ones you're going to see with all anti-seizure medications. So somnolence, dizziness, nausea, vomiting, headaches. But there are some more medication-specific side effects that we should keep in mind. So with felbamate, you can see irritability, and there's a risk of hepatic failure and aplastic anemia. With brivaracetam, just like levetiracetam, there's possible effect of irritability. With perampanel, you can see aggression and hostility at higher doses. And with rufinamide and cenobamate, they should really be avoided in patients with short QT syndrome. Okay, they do have interactions with other medications like valproic acid and lamotrigine and contraceptives, just because of the way their enzyme activity is, and it can affect their metabolism. And lastly, because of those effects, we really need to monitor labs in some of these medications, more specifically felbamate, rufinamide, and cannabidiol, just for some things for us to keep in mind. So that was kind of a brief overview of some of the newer maintenance anti-seizure medications. And that's about it for a talk. Any questions?
I have a comment more than a question. I brought some samples of the different testing devices. So if you're not familiar with some of the new devices and you want to see what it looks like, it's very similar to like a Narcan distribution device. And so they're over here during lunch if y'all want to mingle and take a look at them.
Quick question. Can you talk a little bit about the use of seizure prophylaxis for febrile seizures? That's a common question will get asked, and probably that one that pediatricians are hearing as well for patients who have febrile seizures but not a diagnosis of epilepsy.
That's a very good question, and like you said, it's often brought up very frequently. So seizure prophylaxis for febrile seizures, it's not routinely used, but really more for patients who tend to have really severe and prolonged seizure every time they have a seizure. So it's really just reserved in those settings, and we'll kind of do a brief clonazepam bridge for a couple of days during the time that the baby or the child is going to be sick.
And the prices that you put up for the acute medications are astronomical, and I'm wondering kind of what are the out-of-pocket costs for families, especially if they're buying a kit for school and one for home, and are there sort of ones that tend to be more covered by insurance?
Yeah, so those were, I think, out-of-pocket costs. The price that you're going to get based on insurance, of course, varies. And I will say, I think in my experience, it has been harder to get Nayzilam and Valtoco approved compared to rectal diazepam. And then oral clonazepam, usually I never have a problem getting approved. And even if family wants to pay out of pocket for clonazepam, it's much more affordable. Like, it's around like $10, $15. It's way more affordable. So I think in that regard, those may be some things to keep in mind when you're prescribing rescue medications. I did briefly want to come back to this slide because keep in mind for the dosing, once you get to 15 and 20 milligrams for intranasal diazepam dosing, it actually comes in a set of 2 different sprays, and you need to use both sprays for the 15 milligram and the 20 milligram dose. So for 15 milligrams, it's 2 sprays of 7.5 milligrams. For the 20 milligram dose, it's 2 sprays of 10 milligrams, and both of them need to be used for a full dose. Yes.
So, excuse me, what is the indication for rescue medicine? Is it for anybody who's had even a single unprovoked seizure? Is it for people that have had repetitive episodes of clustering of seizures or prolonged seizures? I'd just like to hear your thoughts about that.
Yeah, that's a really good question. So I think, of course, the really official approval is what we discussed in the first slide with, repetitive seizures. I think in practice, it probably varies depending on the clinician, whether they prescribe after a single seizure versus, patients who tend to have had several seizures. I think in that setting, definitely, I think most of us would prescribe a rescue medication versus with just a single seizure, I think the practice really depends on the clinician.
Yeah, just a quick clarification. So in individuals over 6, usually, you tend not to want to do rectal diastat regarding the insurance. Within our clinic space, the social workers actually have means with which they can get the IV preparations. And if you try to get Valtoco and it's expensive, you can actually try to get the other pending the insurance, and it may be cheaper. So I'm just advocating for that because of the stigma that's usually associated with the rectal preparations.
Of course.